My thing is easy. So welcome everyone to our Eagles 10:30 call. Again, we're twice a week at this point in time on Tuesdays and Fridays, 10:30 Central. We're glad to have everybody on and share information. Paul's got a busy agenda today. We do have a couple of reminders. One is following the video or following the teleconference, we will process the video and post it on us Eagles, useagles.org. For later viewing and for sharing with other people around the country, as you will. And then with that, just remember in your comments, they are potentially, or not potentially, but they will be publicly available. So we want to make sure you are aware of that. In addition to that, today we have a couple of new support features. We have a couple of polling questions that we're going to include today. And if you have polling questions, probably easiest and best to vet those through Jim Augustine. To help us manage those, and then Julian will post the questions when appropriate. So you may have to provide some input on those who are on the active Zoom screen. And then today, Julian, do you want to go over the other new features? I'm sorry, I didn't want to cut you off and things. So.
Yeah, hold on one second. So the new features that we're able to enable are basically just non-verbal reaction to whatever the host is saying. If you look on the screen, you've got several buttons that say yes, no, go slower, go faster. There's a few additional buttons there. You can actually click those and we can actually see how many people have put a certain reaction and see what your reaction are without having to unmute or all that. Unfortunately, this is only available for those who are logged on the computer. Obviously, with the phone, you're not going to be able to do these reactions.
Yeah, and so it's under participants, and if you go to where the more indicator is, there's the infamous Eagles thumbs up and thumbs down indicator that we'll be able to use as well. So, but we can capture that with perhaps some brief questions that come about, and then Julian, as the moderator, is able to see the tally. I don't think it gets captured at the end, but if there's some quick questions that Paul, you want to use, we may be able to use that feature to quickly get a response as to how many people on the phone or on the computer are doing that. So with that, Paul, it's all yours. Thank you. You're muted, Paul, if you want to take yourself off mute.
Love that. Okay. All right. Can you hear me okay now? Good. So good morning, everyone, and good afternoon to those of you in Europe. Just wanted to see if I got a handle on who is who here on the phone. So there's an area code 202 740. Can you tell us who that is? And then we also need to know we got another 407 in there that I'm seeing. It's on the top on the list as we go down. And in the meantime, Julian, if you can try to ascertain who those people are, it'd be good because I'll call on them if I know who they are. Okay, there's another area code 561, etc. That would be very helpful. Okay. So I'm going to go ahead. So for those of you who are joining in, I may ask up front a little bit if there's some timelines for some of you. So for example, I know Sandy Schneider, do you still have to get off at 11 or your time? Is Sandy Schneider, is it, do you have to get off?
No, yeah. I'm okay. I'm okay. I've changed my schedule. That standing call, I can go anytime you want.
Okay, good. And then who's Sean there? There's a Sean down there above Tom Collins. Who's that?
It's Sean Kavan here in Hawaii.
Oh, good. Okay, great. Good to know, Sean. Okay, fantastic. You got Honolulu. So let's see. And then again, I'm trying to figure out there's a 202 740. That'd be good to know who that is. And there's another. Say again?
The 202 number, that's me. It's Ryan Garrett, DC Fire and EMS. Dr. Holman's on another call, so I'm filling in.
Got it. Okay, got it. What's your name? Ryan?
Ryan Garrett.
Oh, yeah.
He's
okay.
the assistant medical director.
Yep. So, and then who's 407 and 561? All right. Well, I'll tell you what.
407 maybe Zuber.
Okay, got it. All righty, got it. Chris Zuber then? Okay.
And 561 is Dr. Shepke.
Okay, good. And Shepke. Okay. All right, good. That helps me because I like to call on you guys and I want to know who's on or not, that kind of thing. So there's a few people that may have to get off. So, so first of all, I just want to welcome everybody. And again, thank Craig Manifold, who is the, for those who may not know, the National medical director for the National Association of EMTs, but through his services down there with Julian Maldonado and their chief, they've been fantastic about, and their board of directors of supporting this and making this happen. And what district is that, if you don't mind, Craig? Who are
Craig,
you
it's
from?
Emergency Services District 7 Fire and Rescue in the outskirts of San Antonio, Texas. So.
But I just want to make sure everybody knows and appreciates how much this has been fantastic, and thank you guys for arranging it and doing everything. So because a couple specific things, again, for those of you who may be new to this, is that this is largely the jurisdictional medical directors for the largest cities in the United States, plus some of their friends over in Europe and other parts of the world, and also some special people such as John Kramer, who is the administrator for the EMS section of the National Highway Traffic Safety Administration, Sandy Schneider from the executive director, associate executive director over at American College of Emergency Physicians, and a few others. We have a couple of guests today, such as Amal Matu and so on. And I think I see also a couple other folks that'll be on the line. But I wanted to make sure everybody knew, because this is a public document, and if anybody reads this later, they know who is this, who's the majority of the people that are on the phone. And and welcome Darren over there from Dublin. I see you there. Chris Colwell from San Francisco. All right, so I'm ready to launch this baby. What I'm going to set up today is, first of all, I want to tell you is that India's air quality has immediately improved under the Corona lockdown. And so there may be some silver linings to all this, that we're seeing some clearing of some of the climate issues that have come up over the last little while. So what I want to do is do a quick review of what the likely topics will be today, just so you know what we're going to be getting into. And I'll try to do it in this order, but I may skip around to create flow. I'll make some re-mention of the what we think the clinical course has been, and been running this by people, and it looks like it's working out fairly well. That's going to be what we see. And then one of the things I want to set up as we go through today is that I don't think there's any absolutes in any of these things that we're finding out about. And that as far as I'm concerned, like Obi-Wan said, only a Sith deals in absolutes. And there are so many chimeric and chameleon things, especially with the clinical presentations, let alone our decisions that go along with that, as we'll talk about that today. So what I want to do is, if John Jew is on the line, I don't know if John's here or not yet. Once he gets on, I may want to talk about the pros and cons of various testing things and being sensitive to the sensitivities and specificities, as I call it, insensitive remarks. So we'll see. Since John's not on yet, I'm going to go skip ahead to the next thing. And then what I want to do is talk a little bit about antibody testing and the potential that we have coming along at this point in time. And Peter Anteb, if you're there, I may want you to do that. One other specific thing I want to deal with is, as I call it, the affairs of the heart, and with COVID. And I want to talk about some new strategies that may be coming along, where we may see people may not be able to get percutaneous, catheterization, and what are we going to do in the interim, and what's happening. So that's where you'll see Jim Augustine and Amal and Sandy Schneider will be there. We're also going to talk a little bit more about the pros and cons of that real can of worms, meaning the pros and cons of reusing the PPE. Other things I want to talk about is what may be coming along in terms of federal deployments, whether it's NDMS, military, or whatever. We'll see what's coming down the track there. We have Andy Garrett, who used to be the director of the NDMS, and still has good connections over there, who can help fill us in on that. Then also there's the issues about our standards of care in terms of who we should maybe even waive resuscitation efforts on, and for example, and forego that altogether, as I call it, a sort of announcements and maybe some cautious denouncements of pronouncements in the field. So, what is the risk benefit of that? And we'll try to get into that, both in terms of adults and children. And so be prepared, Dan O'Donnell and Mike Sayer, if you're on the line, and Veer as well. Then the other thing is we wanted to talk about today, I think the big issue for today was the use of ketamine in various circumstances. And there was some, and Mike Levy, Mike Levy is going to probably lead that one as well as we get into that and so on. And then eventually, I think we want to talk about, Stein, will you be able to talk about Pulsara and its new platform, as I call it, the visual elucidations? So
yes, absolutely.
Okay, good. And then there's a bunch of other things. I want to get a report, and John Kramer, if there's anything you have to report from NHTSA, I'd really appreciate that, and so on. All right, so with that, let's get started. So last time, I just want to reiterate some of the points we made, or that that the clinical course of the disease has always been presented as the fever and shortness of breath and difficulty breathing. And that may be mostly what clinicians are reporting, because that's what they see as the presenting symptoms in the hospital. And we're beginning to appreciate there probably may be, as John Jew has always called it, a bimodal curve, that you may have exposure and then a few days later you actually start having your first symptoms, or you may not have any first symptoms. You may not notice it. In fact, you may have something, but you're not noticing it. Most people are reporting sort of general constitutional system symptoms, feeling run down, etc. On the other hand, some people may just present with, as we talked about, anosmia or funny smell, and maybe the only symptom, such as GI, might be the only symptom as well. So they maybe become part of our screening tools, particularly in the pre-hospital arena, that we shouldn't ignore, etc. And that's what the NT community is saying. If you have someone calling in, especially young people, and a lot of times those are actually, they may not have mild disease, but they may eventually show that they are COVID positive. And the other thing is that I think that's been a kind of a theme for me is that I akin this to like high altitude sickness. For example, when I've been on some of our tours with 150 people on board, and all of a sudden we're in Mexico City at 8,000 feet, and they're coming in with these kind of vague, kind of funny symptoms, and they present in different chameleon ways. And sure enough, there's desaturation. So we're sort of seeing the same thing here. And the experience has been that people will come in with so-called silent hypoxemia. They may actually have altered mental status or maybe combative, and that may come down to our talk later about the use of ketamine, et cetera. So just a couple of things I like to always point out is that we need to be a little bit open-minded about who may present with what, and that's going to be part of that whole a chain of things we're going to talk about when you can let your people go back to work, who is actually got symptoms or not. And that leads us into a very interesting point, which is actually the underlying problems that people may have with cardiac issues. There may be a sort of a pericarditis or a myocarditis type picture that's there, which may present either subclinically or clinically, depending on, and particularly once you get into the hospital, et cetera. And with that, I think what I'm going to do is skip over, since John's not there, and maybe go right into that second thing I wanted to talk about, which was to lead into talking about the alterations in the cardiologist approach to taking care of us nowadays. So with that, I think, Jim Augustine, why don't you open up with a couple anecdotes as like a case studies, then Amal, I'd like to have you take over, and I'll introduce you in that time, and then Sandy Schneider, if you have any other remarks to wrap this up, okay? So go ahead, Jim. You wanted to take it?
Yes, very good. So here's two cases. Presentation of respiratory distress chest pain in two 70 to 80-year-old individuals, one male, one female. As usual, our crews begin with making the patient comfortable, and then because of a chest discomfort, do a 12-lead EKG, which shows changes consistent with a STEMI. The patients are taken to the emergency department where they have positive troponin bumps and are then taken to the cath lab. In the cath lab, they're found not to have significant coronary artery lesions and subsequently very quickly found to be COVID positive. They, in both cases, very significant impact on the hospitals with the cardiac alert patients both getting large personnel responses and now large number of people on quarantine. And in fact, in one case, some of the hospital employees turned positive. So with that, Amal and Sandy Schneider, the myocarditis issue related to this virus, and a very significant discussion about cardiac alerts in the face of COVID.
So many of you know that's Jim Augustine, who's on the board of directors of the American College of Emergency Physicians and has been, our librarian. I feel sorry because you're getting hit hard with all the various surveys we've been putting out with the team, but you've been doing a fantastic job there. And thank you very much. Also, you are sort of the head of policy for your own physician organizations. And so that's been a tough one also to see things at that end. I want to introduce, most of you probably know Amal Mattu, who is a professor and vice chair up at the vice chair for academic affairs over at the University of Maryland, and has been asked to sort of champion and coordinate some of the efforts about how we're going to respond now to people with, whether you want to call them STEMI mimics or actual STEMIs, or how we approach this whole issue in the era of COVID and what's happening in cardiology. So you ready to do it? You want to take over, Amal?
Yeah, I think so. Can you guys hear me okay?
Yes, sir.
Okay, great. Well, first of all, Paul and everyone else, thanks so much for including me in your group. It's a really star-studded appearance of people on my screen right now. But I think we have to start this conversation off by, first of all, saying that this whole idea that severe viral infections, especially influenza type of infections, can cause cardiac problems is really not new. It's actually been published for many years, but I think I and many other people probably didn't know about this until very recently. And I first learned about this after a paper in 2018, just a couple of years ago in New England Journal, where, and again, this is before the whole COVID era. And in that study, Kwong and colleagues had published a paper called Acute Myocardial Infarction After Laboratory Confirmed Influenza Infection, in which they actually described a 6-fold increased risk of acute MI in the first 1 week after patients were diagnosed with influenza. Influenza A, they looked at influenza B, and they looked at RSV, and B turned out to be the worst of all. So I think one takeaway point here that we can also make is that different viruses will affect the heart in different magnitudes, and B was worse than A in this particular case. And the presumption is that these viral infections produce a systemic inflammatory response, a severe inflammatory response, and the degree of which can vary depending on the virus. And it seems now we're learning that COVID is really bad in terms of the inflammation. And remember that when people have a type 1 STEMI, it's usually caused by a coronary plaque rupture. And the rupture happens because plaques become unstable. Well, what is it that produces plaque instability? There's a few major factors, but inflammation is a major factor that leads to plaque instability. So if you have a systemic inflammatory condition, especially an acute systemic inflammatory condition, that can turn relatively stable plaques into unstable plaques and produce the rupture. And then a couple of other things that we've learned that viruses do, and honestly, this is news to me, is that viruses can induce hypercoagulability, which also can lead to type 1 STEMI. And then the sympathetic stimulation can also produce type 1 STEMI. But as Jim was saying, we've also been hearing all these reports that patients are not having type 1 STEMIs. They're going to the cath labs and having fairly clean coronaries. Caths are negative. And that seems to be becoming more common in terms of what we're hearing amongst the COVID-19 patients. And what we're learning more and more about now is that these viruses don't just cause the mechanisms that produce type 1 STEMIs, but they also produce direct myocyte injury and myocarditis with elevated troponins and ST elevation, and that can lead to decompensated heart failure and cardiogenic shock. And interestingly, a lot of anecdotal reports that we've been hearing from the Chinese and the Italians just within the past couple of weeks have really indicated that the myocarditis-induced death and acute heart failure-induced death is really common. I heard somebody say that as many as 50% of the patients that were intubated and even died never had radiologic evidence of pneumonia. So a lot of these patients are dying not from pulmonary problems, and they're not dying from hypoxemia, but they're dying from acute heart failure. And then worst of all, these patients often are intubated. They seem to slowly start getting better. And then around day 10 or so, they start slumping backwards and crashing. And the Italians have reported that a lot of the deaths are related to this exact cause, myocardial injury from the myocarditis and inflammation. And so obviously it's thrown a huge wrench into what we're supposed to do with these patients when they show up with ST elevation. And as I'm sure all of you know, the cardiologists are very wary about taking these patients to the cath lab. The ACC did a recent poll. It's very unscientific, a very biased poll, I'm sure, but the majority of cardiologists that responded to this poll, of about 2,000 responses, favored using lytics for STEMI. and the preference for going to the cath lab for primary PCI for STEMI was clearly less than the response for using lytics. So we're involved in some debates even with our own cardiologists, and I'm sure many other systems out there, about what's the best way of taking care of these patients with STEMI, and we're trying to work that out. Just to conclude my comments here, my impression in talking to some of the leadership in the ACC and also the Society for Coronary Angiography and Interventions, my impression from talking to them is that they are favoring still going to the cath lab as their preferred intervention, but the pit doc cardiologist out there is not necessarily on board with what their leadership are saying. So we're waiting on the new guideline to come out, and we're going to have to see how things play out. But I think a lot of emergency physicians are going to be in the scenario of having to relearn how to use lytics in their EDs.
So it is interesting, and I think what you're telling us goes along with what our discussion was last week about sort of our bimodal presentation, where it can be just sort of vague or something going along, and also then people crash with the pulmonary symptoms, et cetera, and then they can actually get better right away, or they really go downhill rapidly into the ARDS with the cytokine storm. It's interesting, is I remember years ago, my former dean some time ago told me, he was a GI guy, that you get a lot of people get a hepatitis along with the influenza, and it's just not recognized usually. And then again, the data that are showing up with people who do make it to the hospital here do have increased LFTs. And this is really striking, that it sounds like the myocardial component is actually maybe even more profound than you get, maybe a little different than you get with influenza. So that's very, very interesting.
Sure.
So Sandy, where's this leaving Sandy Schneider, who's again the Associate Executive Director over at ACEP, American College of British Physicians. Tell us, what is that going in the policy world, or do you see it evolving, since we have maybe a little bit of duality there with the leadership versus the on-the-ground troops in cardiology?
By the way, ACEP calls me the AED.
Yeah.
Yeah, shocking, isn't it?
Yeah. Oh, I get it. Okay.
They actually don't get it. They don't
Sorry.
say I react to an AED, but anyhow, I thought I'd share that with you. So yeah, this is a real issue. And Amol is actually working with the American College of Cardiology and SCAI on these guidelines. He is our representative there. And I mean, we couldn't have chosen a better person to do this. And I thank him for that. And hopefully there will be some guidelines. But as he said, what the college says and what the individual pit cardiologist does is going to be quite different. And I think the next piece we need to do is get some information out to people who haven't used lytics maybe ever, because they've worked in medical centers and didn't do it during their training, and then worked in medical centers. So that's going to be our next challenge. I also wanted to let you know that the ACC and SCAI are talking about whether or not they are going to promote a relaxation of two things. One is pre-notification of emergency departments that a patient's coming in with ST elevation, because of the number of patients who, it's no longer just a quick look at the EKG. You really have to sort of stop and think, do they have COVID symptoms? If you've got an echo there, certainly wall motion abnormalities would be appropriate. So they're talking about releasing or relaxing that. They're also talking about working with CMS to get rid of the door to balloon, door to EKG, all of those parameters, because it really is causing us to make much too hasty, I guess the word is, of judgments for these patients. So that's that on this. The other question that's coming up, just to throw it out there and be because this is what we're challenging with, is what to do about cardiac arrest patients. Certainly there are two groups. There's the group that Paul was describing, who come into the hospital or on the vent, are not doing well, who have a cardiovascular collapse, and the time frame of this is, they do, as Paul said, either look like they're getting better or maybe they're not, but then they develop a sudden cardiac collapse. The mortality of that event appears to, if they go into arrest, appears to be as close to 100% as I've probably seen, in that no one has reported somebody coming back and surviving from that cardiac arrest. So that one may be less of a question. The other question is what to do about outpatient cardiac arrest, and whether to do an increased call in the field. So I throw those two things out. And then, just because I have the floor, let me finish with sort of the ASEP report. There's a bunch of things we're working on. Do you want me to do this now, Paul, or you want me to do it later?
Please go ahead. I think so. Unless anybody else has a time thing. John Kramer, do you have a time crunch, or can you hang in here for a little bit?
This will take just a couple minutes. So there was a huge legislation that was passed last evening that is going to really change things a lot, both for, I think, you guys and certainly for people who work in the ED. First off, they said that medical screening exams can occur by telehealth. They also put out telemedicine codes so that you'll see a lot more telemedicine going on because now people can get reimbursed at a fair rate for that. They've removed many of the barriers for getting licensed and practicing across state lines. And they've, can't read that. The big one that I think for you guys is that ambulances can now take to alternative locations. These include doctor's offices, health centers, urgent care centers, and federally qualified health centers. So there's, I think, looking at that legislation is going to be really important right now, because there's a lot of stuff that's in that legislation. They also put out some things around the supply chain with FEMA, and then the FDA has finally approved the first sterilization method for reusing N95 masks. And they have that on their website, or I can certainly get that to anybody who wants to have that particular paper. And then two other things that are coming this week to keep your eyes out for: the NIH is finishing their guidelines on treatment. I don't know how much this is going to affect you guys. It really kind of starts in the emergency department, but Steve Cantrell is on that task force. Interestingly enough, Tony Fauci has been involved with that task force as well. Not on an every hour basis, but mostly every time they meet. And Steve's been able to get and apparently Dr. Fauci has been very interested in how things are really going on in the field. So we put that in. And then the final one is ASEP will be publishing an online, we're calling it a field guide. Remember the old field guides to making a bonfire, or field guides to identifying trees? This is a field guide for COVID. It's a rough document where, you know, the editing is going to be very, very slim, but that'll be up and available to everyone on Friday.
Right, that's great. Thanks a lot, and just thanks a lot for being part of this, as you have been for the last several years. It's just really cool to have you in your position and leading the cause and the charge there. So fantastic. Stay healthy, please. We need you.
Thank you so much, and everyone here, please be safe and be healthy, please.
Yeah. So I wanted to, if I can, just because we're just talking about what's happening at more on the federal level. John Kramer, are you on the line still? And is there anything you want to add in, or just listening in? Or where are you on that? On anything that you could contribute at this moment?
Thanks, Paul. I really appreciate listening in. More, in all honesty, from a real world perspective, and to hear about clinical things, because the only thing I've heard about for the last however long, just like most of you, are the administrative things and how can we make sure that things are working. I will just share with folks that, all right, very briefly, there is, as a part of FEMA, now that this has been stood up, there is a healthcare systems resiliency task force that has a specific line of effort that is working on EMS issues. Our Office of EMS is the lead for it, but we've got folks from the Federal Interagency, all of whom have EMS experience, as well as a number of stakeholder organizations contributing as they are able to. Very productive we're addressing not only the pre-hospital, but the interface with the healthcare system, the interface with the out-of-hospital system. And even though we talk about EMS being part of the out-of-hospital system, in the context of this planning effort, it is the nursing homes and long-term care facilities and home care facilities and dialysis centers and things like that. There's a lot of work going on the telemedicine side, primarily on the clinical side, working to both educate healthcare clinicians and also to use the telehealth resources as a healthcare extender, particularly when healthcare providers have been affected and have to be quarantined. Somebody had raised the crisis standards of care issues, significant discussion that we're working on right now. There are a lot of issues related to making sure that the at-need or at-risk healthcare populations are also addressed as we continue through the response activities. So there is really a lot going on. I appreciate Paul and Craig and a couple of participating on some other conference calls when we're focusing on clinical issues. I appreciate everybody's feedback and input into those things. And I'm going to stop now. If there are any particular questions, I'm happy to answer them, but I'm more interested in getting feedback and listening to you all.
So listening to both of you, just so you know, is that the pivot here is that we will be talking about when we forego resuscitation and feel out of hospital cardiac arrest, as Sandy brought in. That's one of our topics today. Another topic today is that it's been a near and dear to the heart of the people. I just got off a conference call with the Florida people because there are not only a lot of nursing homes, but high rises with elderly people there. And I think that's a model for the rest of the country. We need to be looking at what do we actually do about that. Should we actually be proactive about going in there? So we'll talk more about that later, Peter, if you don't mind bringing that up. And then the other thing is that I think a couple things that this conversation is sort of brought to mind to me is that based on what I've told you last time was that silent hypoxemia or, you know, the high altitude kind of situation that may be going on in the program and people don't even know they're sick. Means let's have our pulse oximeters out. And I've actually, people we've sent home, and I think in some places people are sending their patients home with pulse oximeters as they go there. And also, it sounds like we need to get our 12 lead EKGs out of it. That doesn't cause any kind of a PPE problem at all, and to be looking for that as well. Those are two things that are a little bit different than what we've seen in other disease processes, particularly influenza. So,
I can save everything, but I can't.
What's that? I'm sorry, you're talking to someone else, John, I think, right? So
Yeah, my apologies. I thought I was muted,
okay.
folks.
That's fine, no problem. And by the way, this is recorded. Everybody knows on it, and we have it on our website with the Eagles, etc. All right, so let's move on to the next part. And I guess what we can do is I just wanted to briefly see if we had any, or just because their time may be different, our people from over in Europe. Godo Savinsky from Hamburg was going to get on, but they have an influx of patients being brought in from France, and that's why we haven't been able to get a hold of Pierre or Carly. They've been very, very busy over there, and things were really ramping up, not only in France, but now Germany as well. And you know, another person I was going to have on, I don't see him on, is Massimo Antonelli. One of the reasons why I wanted to bring him on, he is the head of the emergency department as well as the ICU. He's actually a critical care specialist at the Catholic hospital, Gemelli Hospital, which is like, you know, the Pope's hospital, and he is the primary person there. And he's the person who invented that helmet thing. I'm talking about 20, 30 years ago. And I was actually interested in hearing a little bit about their use there, and if it came in to be very helpful there, which I suspect it was. I wanted to get more follow-up, so we'll pop in. I'll tell you, I see Darren Murphy's in there from Dublin. Darren, I don't know if you want to pop in, if you got about if you don't mind, if you just tell us a little bit about what's going on in Dublin and what's happening there. I think you guys have got it fairly better contained than the rest of the UK, if I remember correctly. Can you talk to us by any chance?
Hi guys, hi Paul. Thanks for including me in this group. It's amazing to listen to you guys. Obviously, I'm not a medical person, but I just have just the way things are going here in Ireland. we're very restricted since the weekend. Everybody's required to stay at home, save go to the pharmacy or go to food shopping. Everything else is closed. Everybody's required to work from home, so all businesses are closed here. We're lucky because, well, I personally think we're lucky. Our Taoiseach, our Prime Minister, is actually a doctor by profession. So we know when we're getting messages from him, he is understanding the language that's coming from the WHO and from his medical advisors. So in that, there's great comfort in that from our point of view.
And Darren and Ryan, Dr. Ryan wants to, is it Michael Ryan, if I remember correctly? He wants to tighten things up even more so there.
Dr. Michael Ryan is with the WHO, and he's also an Irish guy, so there would be clear communication between the Taoiseach and him.
Okay. And
as such, we've taken it very seriously, and hopefully these restrictions are going to pay dividends in the end. You know, and people are starting. Well, people weren't really paying attention to the social distancing quite as much as they should have, and that's why we've had these further restrictions. We seem to be kind of a little bit ahead of the curve, and our testing per capita is, we've been told that it's higher than any other country, and certainly in Europe. And we have surpassed Singapore in testings now, in per capita testing, that is. So hopefully things will be good, but again, it's just one of those unknown things, isn't it? You know.
Yeah, well, thanks for contacting me. It's really great to have you involved, and Darren involved in security issues, and also it looks like you're in the music business there, right, Darren? So I'll leave it at that. So thanks a lot, Murph. So let's move on to some of the other discussions, trying to see if there's anybody else on from overseas at this time. I know the Manila person was going to try to get on board this time, and I don't see her on board with us right now. So anything else to add there, Darren, before we pivot away from the land of Ireland? So, okay. So, okay.
No, thank you very much, guys, and thank you for letting me listen into your knowledge.
Hang in there. Okay, so let's see. Let's then move on to our discussions. Let's go ahead and talk about that specific issue about cardiac arrest and what we're going to do in terms of if we're going to forego resuscitation. Should we change our policies? Currently, a lot of what we do generally is, even if we have someone, we show up and they're asystolic, you know, no bystander CPR, maybe unwitnessed, and we know it's probably going to be a poor outcome, but we just do it because it's probably, at least gives us some skills utilization, and there's always this hope that there's a miracle case, etc. But should we be changing that practice in here, and actually should we liberalize that about who we would not do resuscitations on? So I think what I'll do is, should I go ahead and have Dan talk about this one? If you are, Dan O'Donnell, are you on the phone with us? Is Dan here with us? Nope, lost him, because he was the person that was helping lead that one on terms of, you know, of looking at if we do that. Veer, do you want to tell us what you're adopting down in, if you're there, are you there, Veer, from Fort Worth? And I don't see Veer either as well. So this may be one where it's going to, does anybody want to pipe in at all and say they're doing something different or thinking about doing something different in terms of pronouncements or actually foregoing resuscitation efforts altogether? Well, if not, then I'll just go ahead and move on to the next topic. And who is that?
Can you hear me? Joelle.
Okay, go ahead, Joelle. You go first.
Yeah, so Joelle from San Diego, go ahead.
Yeah, one of the things, and I apologize, I have a call, shoot. Let's call him back. The County of San Diego has actually pulled together a committee that includes pre-hospital and the hospital that's about crisis standards of care. So we're going to be discussing this in tangent with the other hospitals because it should be a discussion throughout the entire health systems. So when I have that report back, I'll let you guys know. But just so you know that that conversation is taking place in San Diego.
Okay, yes. All right, fantastic then. So I guess at this time, unless we have any of those other people who are posing the questions, that they're not on the line, et cetera. Anybody else want toss in anything about that. I think that one of the conversations that I had that came out of that was that probably if you had someone who is asystolic, unwitnessed, and particularly if they're an LD person, did not get bystander CPR, that their chances are probably of making her infinitesimal, and that may be at least a starting point, and so on. Jeff Goodlow, you're usually on top of this stuff pretty well. What are you guys doing there? Or do you have any plans along those lines? Jeff Goodlow from Tulsa and Oklahoma City.
No, I think we're just watching carefully at this point. There certainly is a lot of interest as to what limited resuscitative measures may come in the next few weeks. But honestly, I've weighed in at this point that because there is so much unknown, I worry about the slippery slope of ethics, calling these resuscitations from the start. I just don't think we're there yet.
Yeah. Okay. Okay. Well, that's good to know. Anybody else have an opinion?
Can you hear me?
Peter Antevi from Broward County. Is that where you're from? Yep.
That's where I'm from. I actually, I'm about to R&D a protocol from my good friend Tom Bouthillet up in Hilton Head. I can share that on my screen real quick if you guys would like. I'm sharing it now.
And for those who don't know, R&D is it's rip off and duplicate, right? You're not researching dead end, right? All right.
So here you see, and Tom, just a great friend, and they do some very good stuff, but here you can see their protocol, which is in place. So they have a first person coming in, and if the patient's history of a cardiac arrest is known and does appear to be of infectious etiology, the first unit should request only the number of rescuers that are necessary based on all considerations, witness versus unwitnessed, shockable, non-shockable, reasonable chance of survival to hospital discharge, logistical needs, and then they should advise if they need a second or third unit, if they need the N95 mask. And then here's the line here. Consider early termination for unwitnessed asystolic arrest. Our survival rate for that cohort is 0% over the last 10 years, according to CARES data. So I spoke with my EMS chief this morning, Juan Cardona. I forwarded him this protocol. He had already emailed me last night regarding it. And so that's why this topic is very interesting to me, and I'm interested to hear what everyone else has to say. That's it.
Okay, got it. So,
hey, Paul, it's Manifold. If I can join in too,
sure.
We're doing something very similar, and right now we're not in a position to change things, but we're along the lines of our protocol change does say to consider early termination, but I would add caution as we develop. I think it's wonderful to be collaborative with bioethicists and community standards and as we look at the crisis standards of care. But I would be cautious for our EMS medical directors, because you are the one who knows what the environment is for our personnel, and we understand what the risk is for our personnel as well. And so you have to do an extremely good job of educating those members who might be sitting with that committee and give the perspective, because they normally don't get to see the patient population that we do. And again, you are the one who knows your environment and your personnel and the risk involved to them the best. So thank you.
So possibly, if I'm sort of sensing what I'm hearing here, is that it'd be probably good to have a plan in place, but maybe not start pushing that. I kind of appreciate, that's why when I wrote up this topic, if anybody saw the agenda, as I said, assertive announcements and cautious denouncements of the early pronouncements, et cetera. So there are those considerations to be had. So maybe we're not there yet. Maybe they're there in New York now, for all I know. But so at least be thinking about this, and it's on our front burner, or at least back a little bit towards the back.
For what it's worth, in San Francisco, we're doing essentially the same thing. We've got those ready to roll, but have not rolled it out yet.
Yeah. Hey, Chris, I like the background. You look like a news anchor there, right? Reporting from San Francisco. It's so cool.
I'm trying to hide the messy office that I have in the background.
I think that's great. Okay, you may get the prize for the best background. I was trying to do it with my transcendental meditation.
That's a nice one too. Come on, Dave's in Mars right
now. Who is this? Miramontes?
Yeah, you got to see his.
Are you there, David? I got to see San Antonio. What do you? What does he have set up?
He's in outer space. Go to gallery view on your top right.
Okay. Well, I'll let it go for now. So let's move on. So yes.
Jim Augustine, got to jump in. So yesterday's discussion about this, Rob Dunn put what was going on in Detroit and Michigan, I thought was a real useful protocol.
Okay.
Veer Fithalani from Fort Worth also contributed this Japanese guideline on over age 73 asystole unwitnessed, very low resuscitation rates. And then Dan O'Donnell commented and really was asking the question, who really should be writing up these issues? And Paul, Pepe, I think you have really a good perspective on this. If you could enlighten us with what an FDM is.
An FDM? Oh, yeah, I learned that from the Surgeon General about 20 years ago when I was sitting to him at a meeting, and he leaned over and he was hearing all these organizations talking, and 40,000 members, 30,000 members. And I asked him what I was doing here. He says, well, you guys are the FDMs. And I go, oh, okay. And then I sat back and then I folded my arms again and I leaned over again towards him. I go, what's an FDM? And he goes, final decision maker. So, so the point is that it may actually end up being up to us and is the medical directors who write those policies and do the training, et cetera. But then you have to be concerned that in some states, in Texas here, we have a lot of ability to be autonomous to some extent in this arena. And in other places like California, you do have regulatory, things. In some states, for example, all the protocols are statewide. So you may have to, respond and know who's got the, who is the FDM under those circumstances. But ultimately, I think it really has to be us discussing if this was your family member, what would you do? And I think that's a really good way of approaching this in the first place, et cetera. And I don't mean for our individual paramedics, but for us to make the decision about how we're going to approach this. So that's just my general opinion. But, we actually have some of this written up already if we get to that point. And this was done quite a long time ago, like in Minnesota and here in North Texas and various other places, New York State, even in the state of Utah had a really good protocol for even EMS about what we're going to do and when we're not even going to transport people to the hospital, let alone resuscitate them. So there are existing protocols and we can maybe get those together. So unless there's something else, we can move on to the next topic. Is there anything else anybody wants to add to that? So, all right, if not, what I want to do is then pivot over to one of the things that I do want to look at is this issue about the telemedicine era. And Stein Bronsky from Colorado Springs, you've been actually sort of working on this as well, the issue about how we can enhance our ability to maybe even have the paramedics do some telemedicine so they don't have to go into a house per se, or they can talk to the facilities about a patient, et cetera, and show them. So what are you thinking along those lines? What's out there and what can we do?
Can you hear me? Okay. Okay, great. Having some internet connection issues. So us, like I believe a lot of people are trying to figure out how to minimize exposure of our EMS personnel to patients that we don't need to be exposed to. One, to help conserve PPE, but just to decrease the amount of potential spread and exposure. We are utilizing Pulsera right now. They came out with a new application called Pulsera Patient. And it is instantaneous video telemedicine app that any provider can send an invite to any patient and be able to telemedicine and see the patient and talk to the patient without being physically present. You don't have to be a user of Pulsera communication system to use this. It's something that they're offering for free within the Surge. They're not the only company that's offering something like this. Mike Levy up in Alaska also mentioned that Good Sam is another company that he's looking at that does this. I think the importance of this type of telemedicine is understandable because from an EMS provider, we can use it from a physician or APP provider. We can also use it right from dispatch. If you have an EMD process or whatever your screening process is through the dispatch center, if a patient is deemed low acuity enough to not need an immediate physical response, the dispatch can push off the invitation or push it to a secondary provider that can push an invitation immediately to a patient and be able to have video conferencing with that patient within a couple of minutes, if not sooner. And we've launched this over the last few days, and we've been testing it, and it has been working well. And it is really, we think that as we get the flood of our numbers increasing out in our area in Colorado, this will be something that is used more and more to try to limit the physical interactions to where they are actually needed. If anybody would like,
can I just give you, can you give us 2 or 3 different scenarios in which you might use it? For example, you come to a door and you talk to someone inside, or can you use it to talk to the hospital or show the patient, or give us a couple of concrete examples then.
Sure. One concrete example is that someone calls 911. The dispatcher goes through the questioning process. They are sending off an ambulance or a unit to go evaluate this patient as we normally would. During that time, instead of the unit just showing up and knocking on the door and personnel going in, they can push an invitation. The EMS providers themselves can push an invitation to the patient to launch the video application, and they can start an interview process and take a look at somebody and see how they look without needing to enter the house right away. They can assess they do need to, or that can be handled without a physical and this would obviously save an exposure. It would save a save PPE, and we have a lot of patients that qualify for this because they're calling because they're concerned and they're the worried well, but we don't really have a lot of ways to assess if they're the worried well unless we are physically interacting with them, and this helps kind of bridge that gap. Another way that this can be used is if you have certain tiers of patients that you have decided through your medical direction or through a PSAP that tier of patients need to be evaluated by a higher level or qualified provider, then that invitation can that call can then be transferred to a physician in medical control or to the ED, where people that are already on shift can push an invitation to a patient in their house, and they can do a full medical telemedicine consult with them from the physician level. And that's also very valuable at this time. Another way that this can be used is actually inside the facility, where, and we haven't started this locally, but it has been already used in Seattle and parts of Texas, that within the facility itself, you can have the nurses or the physicians with the invitation being pushed into a phone that's in a patient's room, and you can telecommunicate with that patient. You can add family members in so that they can see the patient, so that you're minimizing the amount of time that you are walking in and out of the room and having to don and doff PPE and minimize exposures. And so it can be used across the board, and it's very, very user-friendly, and I think potentially very valuable.
Okay, so let's now ask, anybody want to ask him some specific questions? Or, well, first of all, let me just put in there that I picked up on the word you said, free. And actually on my agenda here, I basically said, are we free to use the Pulsara platform for telemedicine? And you have no conflict of interest yourself. You're just basically an end user that thinks this is a really cool thing. So is there a particular mechanism in which people can get this or start looking at it? Or how does that work?
Sure. And again, I don't have any conflicts of interest with this company. I think they're doing the right thing. We already were utilizing them for our EMS communications. And so it was an easy an easy jump not there or have never used it. It is extremely user friendly, and what we're talking about here is their patient telemedicine application, which is different than their full EMS communication system. So you don't need to be bogged down in that arena. But if you're interested in using this, it's as simple as going to their website, which is pulsera.com. And right there, they have the COVID page, and they offer the free module right there. And you as a provider, or anybody that you want to be a provider, if it's your EMS crews or your supervisors or physicians, you sign up on the website as a provider, and then they will create an account for you instantaneously and send the information about how then you activate a telemedicine call. And it's really as simple as that. From the first time a week and a half ago that from the first time a few days ago when we started to trial it, from the time that I went on and signed up as a provider to the time that I was talking to somebody out in the field took about 15 minutes. And each call after that doesn't take that long. That was the whole process of getting signed up and verified as an account. And I did post all of the information and the links on the Eagles website forum. And then I've also asked Julian to post it under the COVID tab on the website so that it's an all access place for people to look. And if that hasn't been posted already, we will make sure that it does get posted in a public forum. And so it's as simple as that. It's really a three-step process.
Hey, Paul?
Yes, Peter and Tebby from Broward. Yep.
So first I want to thank Stein for doing that. We've been looking for something for the last, let's say, couple of weeks, because right now we're calling patients from the rescue outside their house. And so we're kind of using it like the Fred Flintstone way. And I'm already having my chiefs look into it this morning. So thank you so much for doing that.
Okay, anybody else have any reactions or questions for him before I go on to the next subject?
Paul, Mike Levy.
Yes, Mike.
So really great what they're doing in Colorado Springs and Pulsera. I mentioned, I think on the listserv that we're using Good Sam, which is just an alternative platform, a little bit different, I guess, in some ways. Again, free for the asking. The way it works is, of course, it's a crowd sharing app for cardiac arrests, but everybody is, geolocated. It has a Z-axis, so you're looking up as well as just across when you're locating people and providers that are walking around with this. There's a recording feature to it. And what you do when you use it is you simply, once you have the patient's phone number, you simply call them, send them a link. They click on the link and it activates their phone. There's another sort of gee whiz feature where it looks at the pulsations of skin color and calculates a pulse. Remains to be seen how that really works with the person who's doing whatever they're doing, but it's another sort of feature. So I'm not saying it's better or worse. I haven't specifically looked at the Pulsera app, but if you go to goodSamApp.org, and again, I have no ties into that. The creator of this thing, as many people know, is Mark Wilson, a neurosurgeon in UK, and it's used throughout Australia and Europe. It's the thing that Freddie and their group in Denmark use for their dispatch-associated, one-way videos on patients and stuff like that. So just throw that out there as another opportunity for people too, not saying better, worse, or indifferent.
Right. And hey, listen, while I got you on the line, what's happening in Anchorage? Where are you on this? Are you still waiting for the pulse, or are you in the middle of it, or what's happening?
So are we talking about using the app? We are. If you're
No, I'm talking about, I'm pivoting over to just your overall situation in terms of volumes of cases that you're having.
I think we're probably doing better than most. Alaska has 60 some cases, most of them in Anchorage. Typical shit show with regard to how the hospitals are doing and the like, repurposing ambulance bays, negative pressure, just movement of patient issues, huge homeless population issues, co-opted ice skating rinks, the big arenas we have here in town, as well as the universities for, off-site care. very active EOCs going on at many different levels, probably pretty much the same thing everybody else is dealing with.
Yeah. And then you not only have Anchorage, but you got large number of rural areas, and that's been an issue and concern. You know, for example, Sandy Schneider brought that up last time and wanted to know, and Mike Osterholm, when he was on last time, also said we're going to see things moving from the blue states to the red states, as he put it. And so I just want to know if you can give us an idea then what's the relative issues there? Like, for example, is it resources? Is it less cases but more less resources as well, or what's the general impression there?
Well, it's a mix of a lot of things. On a state level, again, we haven't actually farmed this out yet, but there are certainly considerations for whether or not we use tertiary care hospitals here in Anchorage and make one of them just the only place that COVID patients would come to from across the state, and then looking at how we would resource air assets pretty much to take people from an area basically from lower 48 standards from Minnesota to Texas. Yesterday, I got a call from a medical director who brought up the following concern. In Alaska, in a place called the YK Delta, there's lots of silicates and stuff. And so bronchiolitis is really, really common in that age group in the kids. So we end up actually having bypass on these small little hospitals at this time of year because there's so much bronchiolitis and so many sick kids. So now the bronchiolitis kids who could be COVID, the air carriers refuse to fly them. They used to just go in routine sort of caravan, Cessna caravans and stuff like that, and go from a very small village to a little larger village where there are more resources. So just as recently as yesterday, this came up of how we're going to move these little kids, whether it's going to be a $10,000 a pop, medevac just to get them the 100 miles or so they need to go, or elsewise. So I guess that's one flavor of what we're doing up here. It's maybe a little bit different, some challenges that others may not yet have to face.
And we heard last time that the bronchiolitis issue is, like Joelle said in San Diego, since she looks after kids a lot, that's been a particular problem there as well, right? So.
Absolutely. I think they are little vectors of COVID disease probably, but we also have seasonal bronchiolitis, which is pretty extreme up here.
So the other thing is that we may be looking at, like, for example, just looking at the email, there's Godot still at the airport in Hamburg. They're taking patients in from France now. So we may see that there are going to be overflows in different areas. That's interesting. And I'm going to bring up the issue of that. For example, let's say New York continue to get bad, or our friends in Meg, I think I see Meg Marino and down in New Orleans, if it gets to a certain part, are we going to ship people out? Or are we going to set up other resources? And that may be a good excuse for me to then now to segue over into Andy Garrett. If you're on the line, Andy, are you still there? See if I can find Andy Garrett here.
Yep, just had to unmute late.
Yeah, okay, so let me just introduce you. So I told you before, Andy has been really fantastic. He's currently working over at GW and doing a lot of great educational stuff, but was the former director of NDMS, but still will be heading back over to HHS sometime soon. So has some insight, not direct insight, but has some insight into if and when they would use NDMS for these kinds of situations, or any other troops under those circumstances. What can you report to us then?
Hey, Paul, just, normal government disclosure. I'm not representing the government in my comments, so I'm just speaking as Andy. So if you like him, hey.
You may not know my acronym, NDMS, that's the National Disaster Medical System that has a lot of the DMATs, the Disaster Medical Assistant Teams that can be sent out. Go ahead.
That's right. So you'd asked me to talk real quick on potential sources for surge staffing with military and NDMS, and I'll do military first. Certainly there's a lot of military-like activity going on. I know we've been hearing from Army Corps of Engineers looking at potential surge spaces. You've seen the deployment of the Mercy and the Comfort, veteran from 6 weeks in the Indonesia 2005 deployment. So that's a great resource with a lot of depth that hopefully will be a tangible asset for New York City and Los Angeles too. I think you saw they graduated the uniform services class early, trying to get more folks into the system. They're just trying to boost the number of providers right now. I think there's over 10,000 guards people deployed under Title 10, which means they stay under the authority of the state at a 100% cost share to the federal government. So I think we're seeing that the federal government's taking seriously the need to help utilize whatever tools are in the federal toolbox to try and boost that potential staffing. And I think if anybody knows anybody in the military, over the last couple of days, there's been a lot of activity there as many reservists, including, I believe, some individual ready reserve, which is sort of usually not touched. Those folks have been called back onto active duty, potentially for duration undetermined, but potentially thousands and thousands of assets that may be utilized to help staff whatever facilities end up needing staffing, whether they're military or surging into support civilian type activities. So DoD's got a lot going on. NDMS has been active actually deploying folks for support of the CDC quarantine mission with the cruise ships and others, staffing missions for several weeks now. I think one of the challenges is going to be operationally, NDMS relies on civilian medical personnel, so doctors, nurses, paramedics, folks like us that do this type of work on a day-to-day basis. A lot of you on the call are associated with either a DMAT team or one of the IMTs. And it's a tough time to deploy. So NDMS is certainly experiencing that, getting a lot of requests for folks to deploy. And that's a challenge right now. It's much easier when you're maybe deploying to Florida or pick your state, and you can rely on the people from the rest of the nation to back you up. But when we're all sort of experiencing the same thing at approximately the same time, I think we're going to see a lot of bandwidth issues in terms of having that be a big fighting force that's going to be able to force multiply at the local level too much. And because of that, I think a lot of the states are coming up with creative ways to explore how they're going to do their own staffing. I saw, open media that New York State, I believe, got tens of thousands of medical personnel to either come out of retirement or volunteer to do work. DC waived licensure here. I was seeing that California this morning started California Health Corps, where they're being much more flexible in terms of how they're going to recruit and staff and deploy medical assets. So I think folks are realizing the need to certainly work with the feds as much as they can, but being realistic about the fact that there's probably no cavalry coming other than in particular situations where there's a target that needs a specific federal asset that's been worked out. So I'll keep it short there, Paul. Is that what you're looking for?
Yeah, and I see if anybody has any questions. I just wanted to get a report to get put our finger on the pulse of what might be happening there, what we may need to expect, and also to have some, let's say, wariness that they're not going to be the cavalry coming out of the, coming out to rescue us, and we really are going to have to some extent, rely on ourselves. Correct?
Well, I think, this is different than a situation where you've got a disaster in one local area where NDMS in the past has been able to surge hundreds and if not more over months, thousands of responders. The challenge right now is that getting people to be able to deploy means they have to be freed up from their local position as well. So it's not that there's not plenty of folks that have responded and will respond. It's just, I think managing expectations is important.
But that's a great way of putting it. And then it's also the rolling. This is not that it's all one big thing. Also, it's kind of the rolling thing, and then you have to be moved from one place to another. It's no way to predict when and where you're going to be needed and for how long under these circumstances. Okay.
Hey, Andy, it's Craig Manifold from San Antonio. Hey, how about like a 2-minute primer on for EMS medical directors if there would be patient movement through NDMS of kind of what to expect on the receiving end, because I bet most of our EMS medical directors maybe haven't paid quite as close attention to those exercises in their area or coordination with their emergency healthcare systems. But maybe just a few words real quickly on what to kind of anticipate or prime for if there would be a large patient movement.
Yeah. Sure. I think, just Andy's personal opinion, I think that's less likely now, given the national situation, the global situation, to see a relocation of patients from area 1 to area 2, but anything's possible. And I think what you're getting at is, so NDMS has a couple different missions. One of them is providing care like in a field hospital type of thing. One of the other missions, and it relies heavily on the 4 federal partners, so VA, DOD, Homeland Security, and HHS, to be able to move patients by air or by ground, either the ambulance contract or through military aircraft from a point where there's a disaster somewhere else in not just the continent of the United States, but all of the United States, where there's a federal coordinating center, usually located out of a major airport, where they bring those resources in, work with case managers and coordinators to then allocate those patients out to hospitals, typically hospitals that are always hospitals that have signed an agreement with HHS to be a participating hospital. So there's a lot of hospitals in that system. There are thousands as of the last time I was current in the system a couple of years ago. And they reimburse a little bit over CMS rates as a carrot to encourage participation in that NDMS hospital system. It doesn't mean that if you're not signed up, you can't be an NDMS affiliating hospital, but there's that percentage point over CMS reimbursement. If you don't do it ahead of time, you lose that little benefit there. But so that's all done through federal coordinating centers, typically run by either the VA or the Department of Defense through the NDMS relationship.
Which gives me a kind of a good segue over to San Antonio and David Miramontes. I don't know if you're on the phone or not, but the other thing you guys are already doing, at least more in the region, is inter-hospital transfers. And how do you go about doing that?
Yeah, so what we're starting today actually is we have a nursing home that popped positive for COVID with multiple staff members, multiple patients. And in order to prevent the dump, so to speak, patients in our hospital system in an uncoordinated way, we're actually stepping up what we call the ITAC, Facility Transfer Authorization Center. Right now, that's me, but it will be evolved into on-call medical directors that will work the magic with our MedCom system. So our public health actually issued a control order for this nursing home, went and did inspections, gave them orders for infection control, improvement, et cetera, et cetera, et cetera. One of the ways that we're going to try and limit the dump is to have them go through a physician before that ambulance is called. And that way we can screen the patient's needs. Perhaps they can treat in place. Perhaps they can get directed for COVID center hospitals. Perhaps they can go to a higher level of care like a long-term acute care hospital in LTAC. Or they can stay in place, and we can suggest labs, x-ray, or something like that to try and evaluate the patient further before we move them to a hospital. So we're just trying to get ahead of the game. I did a little bit of this when I was in DC during the bad times, but this is going to be a promising way where we can kind of get some control over the dump from the nursing homes.
Okay, well, that's good. Well, thanks a lot. And that's a good one for everybody else to be hearing about at this point in time as well. And does anybody else have any other, has anybody else set up, let's say, mechanisms for transfers or transports or whatever? Okay, if not, that issue of for example, you talk about like the nursing homes that got hit. Peter, can you tell us a little bit about what they're doing? This may be a little repetitious from before, but tell us a little bit what they're doing regarding nursing homes and condos, et cetera, down in Florida, if you don't mind.
Yeah, so our South Florida area is a breeding ground, obviously, for many nursing homes, ALFs, and then those that are even not considered ALFs, just basically these big condo towers. Ken Shepke's been doing a great job kind of leading the way. Kind of weeks and weeks ago, we've been aware of this. And in Coral Springs, what we're doing is a weekly webinar with all the ALFs. So I got 52 ALFs in Coral Springs and Parkland. And that doesn't even include these large towers of elderly people.
Yeah, can you actually tell them what an ALF is, just so everybody does understand on the line?
Right. So it's basically an advanced living facility with basically people who need nursing care, LPNs running around, people delivering food, and basically lots of people coming in and out and providing medical services. And so essentially what we've done is we've given them a little primer on what to do PPE wise. We're having them check temperatures on all their employees and check symptoms twice a day, just like we're doing at the fire department. We've advised them to have everyone wear a mask no matter what, no matter if you have symptoms or not. And now we're actually advising them on how to cohort patients once they start getting 5, 6, 10 people in the home who are not actually sick enough to come to the hospital. Every one of them thought that you just call 911 when a patient has a fever. So we have mechanisms in place to actually check on them when people are sick. We've given them an alternate number to call us for help. The DOH gets involved immediately as soon as there's a sick patient. And then people like Randy Katz have even enacted where his hospital has developed a team to go into those homes and test people because our Department of Health is not able to do that. They don't have the manpower to do that. So our Achilles heel is a nursing home, and we're really sticking with them every week. And they're very grateful and appreciative of the help that the fire department is giving them. That's pretty much it.
The idea then is to be more proactive about these assisted care living facilities, nursing homes, et cetera, because they have been a nidus in many a place, including where it started off in Seattle. And it may be in high rises in general, you have a lot of condos with elderly people in particular, but still, or in close quarters in other cities that have a lot of high rises like New York, this is not totally a surprise then. But I want, if you don't, go ahead. Yeah, Peter, because I've got to hurry up. I got to be careful about time here, but go ahead.
One comment that Randy Katz recognized that he was discharging patients from the hospital to the nursing home that ended up being positive. So he's trying to implement a policy where the hospital or the nursing home should not accept a patient from the hospital unless they have a negative COVID within the last 24, 48 hours. So we're looking at that now too.
And then I think at your state EOC has actually looked into this and doing some of this. Ken Shepke on the line. He's the Florida State Medical Director, as well as being our Eagle from West Palm Beach. Are you there, Ken?
He is. He said he may have to be unmuted.
Okay, unmute him, please. Okay, so if you can.
Ken, he's a 561 number. Hold on, let me see if I can. 651. He may have had to jump off the call.
Oh, okay, got it. All right. Well, if he can't get on, that's fine. But we'll try to pick up on him later on. I'm gonna see if there's So he may be the 561 number right there. That's there's someone else calling in for a 561. But
that's him.
Okay, go ahead.
Hey, how are you guys?
Hey,
I just got unmuted.
Okay, good.
Oh yeah, so we thanks to Mike Sayer for giving us that warning about the nursing homes early on. We restricted access to everybody going into nursing homes and putting in screening programs and temperatures, et cetera. Even EMS has to be screened for non-emergency calls. And we actually have a team, task force that goes going around the state to all of them, all the long-term care facilities, to give education to our staffs on how to put in their infection control procedures, screen staff, isolate anybody with any symptoms, even the diarrhea or any of the other less typical ones or the ones that are less reported initially. Put those folks into the room, close the door, call the Department of Health. And to Peter's and Randy Katz's thing, we're doing a program, or we're setting it up now, for what we're calling a step-down nursing home beds, where we've got folks in the hospital. They were COVID positive. They're healthy enough to leave the hospital, but they still need to convalesce. They still may be shedding virus. We don't want them to go back to the nursing home. So we're setting up alternate care sites for that. That may be hotels in some instances. It may even still be the long-term care facility if they're able to clear out an entire wing and just use that wing as the folks that are convalescing. So those are the programs. I think Peter had it exactly right, and so did Mike Sayer. These are the folks that are going to create the tidal wave that will overwhelm your healthcare resources. You got to really, really focus on them and try to keep them from getting sick. These are not the population that's going out to the spring break beaches and catching this. People are bringing it into these facilities to them. So we have the staff wearing masks the entire time, even if they have no symptoms. And we've got screenings all the time. And now the next step is let's give that delay for, so we can unlock our hospital beds, but they don't go straight back into the general population of the nursing homes and assisted livings. We put them in a separate area for them to convalesce.
Okay, good. Well, listen, let's move on then to a couple of things. Since we're already well into it, and maybe we've only got 10 minutes left. What I'll do is on Friday's call, we'll get more focused on the ketamine issue. I think that's playing out pretty well, and it's a very specific topic. And we'll maybe just get a sort of a summary of that later on. One other issue I did want to bring up, and I wanted to see, is anybody at this point in time considering prophylaxis with let's say hydrochloroquine or chloroquine, and is anybody doing that at this point in time yet, and under what circumstances?
Paul, this might be a good opportunity for us to use our indicators. And if everybody opens up their participant page, and then at the bottom, if you're using the chloroquine or thinking about using chloroquine as prophylaxis, there's the yes check button. For those on the Zoom feature, again, go to participants, and at the bottom it should pop up. You can hit yes or no. So if you hit yes, Julian will be able to tabulate that for us pretty quickly. being able to do that and give us an indicator.
And as we're waiting for that, I just want to say my next step, I think, is just say that we'll turf the ketamine thing. I want to talk a little bit about some of these issues like prophylaxis, down the line, and then also talk about the PPE issues again, and just see where we are on Friday as an inventory. But what I do want to do is at least quickly go along and see if anybody has any particular new things to pipe in or what they're facing in a typical, or maybe I'll reserve that for Friday, but there may be a couple people I may call on right now to see how they're doing as we do.
I have a quick question for the group.
Yes.
Are you guys seeing a lot of healthcare professionals, your colleagues, and the nurses and doctors in EMS getting sick? And is anyone keeping track of this at the hospital level? I know we're keeping a track in EMS, but I'm just curious as to what's going on in the hospital, quarantine-wise, isolation-wise.
Peter, we're tracking it regionally, and then, but as far as hospital quarantine and things, those have been up to individual agency decisions with kind of regional recommendations. So.
Okay, thank you.
All right, do you have a results yet by any chance, Craig, or should I go on and just do some of my rounds around everybody?
Oh, I must have missed the poll.
Well, it looks like the results so far was 1 yes and 11 no. Okay, so but what I really do want to know, and maybe we'll talk about this next time, is like under what circumstances are we doing it, to whom are we giving it to? Okay, so that's basically, and then so let's go ahead and just I'm going to sort of let's see who's on the line, and I'll try to capture everybody. If I don't get you all now in the next say 10 minutes or so, because we got to wrap it up. I just wanted to, especially people I didn't call on last week. So actually, Crawford was, in Philadelphia. Is that serious? Are you getting people coming down from New York and getting hit with that, or is that just is that a little bit of humor, or is it actual a circumstance that's coming out? I don't know if you can hear me or not, Crawford Meacham. Okay. If not, then let me go back, and we heard from Libby before, and I want to introduce Sean Covant, who is the medical director for Honolulu. And Sean, is there anything percolating out there? Is it still relatively quiet and you're just waiting for it to crash? Is that, everybody see Sean there, or can he be, does he need to be unmuted? Is that what is happening here? Sean Covant?
Are we here, Paul?
Yeah. What's happening yet?
So far we've had a decrease in volume in our calls. We haven't had any providers that are positive. We've had 1 or 2 non-work related in the hospitals, but so far we're holding our own.
Okay, got it. All right, and then we'll come back to you, and thanks, and welcome to the club here, so to speak, right? And let me see who else is on the line. Anything new? Are you on from Fort Worth? I tried to call on you before, and I think we'll probably going to come back later to the issue of the termination. We had a little bit of a discussion about that, and sorry we missed on that. RJ Fresco from St. Paul, we haven't heard from you for a while. What's going on in the Twin Cities?
Nothing new. Very quiet here. State's had around 500 cases and 9 deaths.
Okay. Are you guys, is it really pretty tight there, more than, or just the same thing where only groceries or pharmacies and you can take out food? Is that anything new there? Or are you guys doing anything different?
Nope. It's the same as the rest of the country. Everything's closed except grocery stores and pharmacies.
Okay. And Scott, we haven't heard from you. I always love to hear from Scott Gilmore. Anything going on in your neck of the woods in St. Louis? I don't know if you're there or not, Scott. I think you are. I hope so.
I'm here. Just had to unmute.
Yeah. Right. Okay. Everybody else, be prepared to unmute as I go out. Go ahead, Scott.
So we're just, starting to see our uptick in our number of cases within the community. Right now, we aren't too stressed with a whole lot of stuff. We're, still in the planning and preparing phase that everybody else is doing.
Yeah. Okay, and then Meg Marino, then let me then, as I'm going up kind of reverse alphabetical order, tell us what you and Emily are experiencing down in New Orleans, because you were guys there. Some people are calling you the new epicenter, right? And so what's happened there? Anything new on your end?
We've been working hard to keep up with the increase in acuity. Our volumes haven't seen a huge uptick. We're maybe down a little bit on volume, but we're seeing a large uptick in acuity. So
Yeah.
we're running a lot more codes and having a lot more deaths over the last few weeks. We've had now 7 of our employees test positive, and we have, I think, about 25 who are still in isolation at home with symptoms. And we're just doing our best to keep up with our ever-growing population of people in our community who have COVID.
Yeah. Okay. Got it. All right. So, thanks for your guys' detailed response before. It's always been very useful. What I might do is, Joe Hawley, I haven't talked to you about Memphis recently. What's going on there? Anything new?
Well, I was just posting. We've got 9 positives and about 200 in isolation. But interesting, as best we can tell.
When you say, 9 who? 9 who?
9 employees of the fire department.
That's what I'm getting at. Okay, good.
Yeah,
Okay.
sorry. That's about 1,800 employees total.
Okay.
And as far as we can tell, none of these are work-related exposures except for the last 1 or 2 who got exposed in the engine house. But we don't seem to have any patient care transmission as far as we can tell yet.
Okay. And then I'm going to pivot back over to Chris Kahn to see is there anything new, the report in San Diego? And you guys had the problem with hepatitis A with your homeless population. Is that a factor here as well?
Fortunately, not so far. What we were able to do is, along with the county, set up about 1,500, 2,000 hotel rooms where we can put people who are homeless but positive, or even non-homeless folks who just need some sheltering, that sort of thing. So the main goal there was to help decompress the hospitals as well as keep potentially infected folks out of homeless shelters. As for right now, in terms of our volumes, we're pretty much like everyone else. Our volumes are oddly low, and we're expecting that to change pretty much any day. We do have a few cruise ships that keep coming in and out, but now that cruise ship travel isn't really a thing anymore, that number is going down.
Yeah.
But I will actually be on a call with our port in about a minute about a cruise ship that will be offloading shortly.
Yeah, we have this awkward situation where the governor won't let one of the ships with 4 people already dead on it come into the port in Florida. And so that would have been, our troops would have been receiving those folks and handling it. So it's going to get even more interesting. Again, it's very fascinating to see that not only the EMS volumes are down, maybe because, one of our biggest things usually are car wrecks, and we're seeing a lot less trauma, a lot less car wrecks because people are out there driving around and they're not sitting in bars all night drinking, I presume. I mean, that's my speculation, but it's pretty logical too. That's all gone down. The environment's gotten a little cleaner. The air's gotten a little cleaner, even in LA. And but the acuity of the people we are looking at, it's going up, and that's the one thing I have been recognizing. Anything new to report from Houston, Chris Souders, if you're there?
Yeah, I'm here. 20% call volume decrease, 10 to 15% transport decrease, 7 positive members. Our biggest issue, and I don't want to derail it, but we're having rebellion as to what to do with the fire station colleagues of a fire member who tests positive. Our health department says you have to go back 24 hours from the onset of their symptoms, find out all their contacts at the fire station. Currently, they said we need to treat them as sort of a home environment and they should be self-monitoring. Our firefighters are insisting on being quarantined and put up at a hotel at the city's expense because they don't want to then expose their family. And so that's our current drama at the moment.
Okay.
So if other people are doing something in that regard, it'd be nice to know.
Yeah, so listen, anybody else want to pipe in? Since we're at 90 minutes, I thought that's it. I got to cut it off. This has been a good discussion. Looks like most people have hung in here. And so I'll just continue the discussion with some of the topics we were going to address on Friday, etc. Anybody else want to pipe in with anything? Yes.
Jim,
Who's that?
Jim Augustine.
Yes, Jim.
Chris, a big issue is about etiquette and hygiene around the fire station. Just got off the IAFC, IAFF call, and there's no indication for putting people in masks to move around in the station. There's a lot of other things around the station that can be done, but asking our members to wear a mask all day is not in any way beneficial. And I urge all of you to take that on directly and begin to mitigate this thing about keeping masks on all day in the station. Thank you.
Okay. And then, hopefully we'll bring it up, and Joel, maybe later we'll bring up the issues about hydrogen peroxide and a few other things along those lines as we get to it. One thing I do want to say before I get off the phone, and we've probably lost Sandy by now, but Jim, as member of ACEP, I want to tout the repository that they have on their website. ACEP has a special repository of documents and things, and just want to get a quick comment on that as I got you there on the phone.
Yep, and you're going to have to pivot that over to Jeff Goodlow, who's on the board now. My term ended.
Oh, I see. Got it. When did that happen? In October then?
In November. Yep.
Oh, good to know. Okay, got. I'm like several years behind, obviously. So okay,
Yeah,
but you want to go ahead and have Goodlow talk about it? Jeff, are you there still?
Yeah, happy to just make a few comments. Literally hundreds and hundreds of collective staff hours are going into this. The field guide that Sandy brought up earlier, many on the board are directly participating in that, and I'll be writing a small chapter in there, I think, sometime later this week. It really is an all hands on deck effort, and highly recommend you peruse through that, and also recommend that to your hospital-based colleagues as well.
So fantastic. So listen, everybody, thank you very much. Those of you on the phone still, which is still a lot of people, like around 40, I guess, looks like. But just want to let you know, make sure if there's some topics you want to get covered or discuss in more detail, please let me know so I can put it on the agenda, or at least see if we should explore it with our sort of subcommittee of people that look at this stuff. Everybody who was on today was just great. It was great hearing from, it was interesting because Godo in the meantime has been keeping me apprised about all these people coming in from France. And so things are escalating out there as well. And the other thing I was going to say is that we will probably attack some of these things, such as as I called it, the great barrier grief, which is what are the pros and cons of reusing the PPE? Are there other options, and where are we on that? So let's be prepared for a discussion on that, and whatever suggestions you might have as we get back to that. We covered a lot of territory today. I mean, a lot. And Peter, I want you to come in and do a discussion about the antibody testing that you're about to embark upon, and we'll talk more about that. Armando Clift, I don't know if you're still there or if you're there at all. I didn't see you, but if so, just like to have you involved in that discussion as well as Miami. Okay, so with that, Craig, anything you want to do, or you want to sort of head and shut down?
I think Jim and Julian maybe had a few polling questions. If we can maybe take just a minute or two and go through those. I know we've lost a lot of folks, but it'll be good practice, and we can see if it's a useful tool or not for us. So, Jim, you want to lead the discussions here?
Yep. This 4 questions here very quickly. Just want an idea about call status, shortage issues, how many members diagnosed, and what % of staff on quarantine. If you have a minute, we can check out the system and use it further on Friday, if that's okay. Thanks for taking your time.
Okay. And I just want to do one special shout out, which is the person who we always look up as our ultimate guru is Dr. Michael Kopis. And he had his birthday yesterday. So I'll tell him that we send our regards to him. And so he was born in 1938, which make him 82 years old. So good on him. So, which is great. So, and so far, so good. All right. So you want to go ahead and say we cut it down and say goodbye, sayonara, and see you at the same time, same station on Friday then, right?
You got it. That's the plan.
Craig.
Okay. Hey, is the formatting of this thing good for everybody? Should we change it, or are you okay with this so far?
I think we should make it 2 hours longer.
Yeah, right.
Right, Peter.
So you stay on, Peter. We'll all see you later on. Okay, take care. Bye-bye. All right.
Bye-bye.
Take care. Thanks, everyone.
Thank you all.
Thank you.
Bye, guys. Happy Cesar Chavez Day.
Joelle.